candidate talks that we've been enjoying over these last few weeks. And now we will be meeting every week from here through the rest of semester. If you are a student signed up for to take this for credit, I believe Lauren will put a link in the chat with the spreadsheet to sign yourself in. So yes, there's the link. So make sure you go in there and indicate that you're here. And yeah, we look forward to having you with us as many of the weeks as you can be through the rest of semester. So for today, kicking off this session, we have Dr. Zach Butzin-Dozier. I don't think I got that quite right. I was trying before, but it wasn't terrible.
It was good.
And Zach is a postdoc and an instructor here at Berkeley Public Health. Those of you who've taken 250A or 250B may have had him as an instructor, and today you'll get to hear about some of his really amazing and impactful research that he conducts. So thank you so much, Zach, and we look forward to your talk.
Thank you so much, Jen. Really appreciate that intro. I'll just share my screen here. All right, so thanks so much for joining, everybody, and thank you so much to Jen and Lauren for hosting. So this presentation today will be titled Evaluating Preventive Interventions for Long COVID Through Targeted Machine Learning, and I'm Zach. In today's presentation, I'll first just start with an introduction to me and my work. Then I'll give a little bit of a background on long COVID, the subject area that this will be covering, the data source, which is the National COVID Cohort Collaborative, or N3C, the analysis methods, which are targeted machine learning, and then I'll describe two applications of these methods, which are the NIH-funded Long COVID Computational Challenge, which was a data science competition, and then an analysis evaluating the relationship between the use of selective serotonin reuptake inhibitors and long COVID. And then finally, I'll discuss some of the ongoing and future applications of these methods. So first, for an introduction, I completed my MPH and PhD here at Berkeley in epidemiology and biostatistics. I'm now a postdoc at the UC Berkeley Division of Biostatistics, applying targeted machine learning methods to long COVID using data from the National COVID Cohort Collaborative, or N3C. My previous research through grad school evaluated drivers of antimicrobial resistance in Ecuador and evaluated data through the WASH Benefits Bangladesh project, primarily evaluating drivers of child growth and development outcomes. I'm also an instructor in epidemiology. I'm currently instructing Epidemiologic Methods 1, or W250A, but that I previously was the instructor for Epidemiologic Methods 2 and Intervention Trial Design. So first, for the subject area of long COVID. So we've really made a lot of progress in learning how we can prevent and treat acute COVID-19, but then the long-term consequences of this infection still remain pretty unclear. Long COVID is a really broad range of symptoms across different biologic systems following acute COVID-19. So a big challenge is that there's such a broad range of different symptoms that it's unclear whether there's many different biologic pathways at play, whether we're really referring to an array of different disorders, or how these different symptoms and conditions are linked. For just a brief list of some of the more common symptoms, but this is far from all-encompassing, these can include fatigue, shortness of breath, cough, brain fog, dizziness, anxiety, changes in smell and taste. And so you can see that these symptoms are really not only many symptoms, but also spanning a lot of different biologic domains. We really lack a clear understanding of what causes long COVID, as well as what we can do to prevent long COVID, which then really hampers the ability of clinicians, patients, and investigators to design interventions that can help reduce the impact of this condition, which is really debilitating for a lot of folks. There's also there's a huge disparity in terms of diagnosis and true incidence rate. So in different cohort studies and randomized trials have found that somewhere between 10 and 30% of people who have acute COVID-19 will then develop long COVID. In contrast, most electronic health record data sets like N3C report that more like 1 to 2% of folks who get acute COVID-19 will actually get diagnosed with long COVID, which I think is really is kind of makes sense from a clinical perspective as well, that there's not that much that a clinician or a patient can do with a long COVID diagnosis. So there isn't necessarily a ton of value in diagnosing this condition until we really have promising treatment options. So here, I just wanted to kind of lay out a few of the predominant biological pathways of long COVID, of hypothesized biological pathways. I do want to make two notes here. Similar to the symptoms I listed on the previous slide, this list of 6 biologic pathways are not all encompassing. There are a good amount more potential biologic pathways. Similarly, this groups together both the causes and effects of long COVID. That, for example, depending on how you consider something like tissue damage. So tissue damage may be a downstream effect of severe acute COVID-19. And so you could view that as a symptom of perhaps long COVID. Alternatively, it could be that that is a kind of intermediate or cause of then later long COVID symptoms. So in this figure, I'm kind of lumping some of these factors together just for conceptual clarity. So in terms of the most common hypothesized biologic pathways, so we have persistent SARS-CoV-2, where we have remnants of the SARS-CoV-2 virus that causes COVID-19, and then some people just are unable to purge all of that virus, and then that could lead to long-term sequela of COVID-19 or long COVID. Similarly, COVID-19 elicits a very strong immune response. And then in some folks, this strong immune response that may be referred to as hyperinflammation or a cytokine storm then begets more inflammation. And so there's a kind of a cascading effect where an individual will continue to have this dysregulated immune system. And that's one hypothesized mechanism, again, of long COVID. Similarly, this immune disruption could trigger or elicit different autoimmune disorders. And then inflammation or immune system and stress are highly linked, where the two systems downregulate one another. So typically being in a hyperinflammatory state will then suppress your body's stress response, which then, again, has kind of cascading impacts. But similarly, and perhaps more conceptually, getting COVID is really stressful. Getting COVID is stressful. The COVID pandemic overall has just been a stressful time for everybody. And then having to isolate is very stressful, whether you're hospitalized or whether you just isolate in the home. So that could have kind of rippling effects through the body. In a bit more straightforward, that it's been well documented that acute COVID-19 and long COVID are associated with hypercoagulation or clotting and clotting and platelet dysfunction. And then, as I mentioned, acute COVID-19 can lead to tissue damage, can lead to organ damage of the lungs, the heart, the kidney and liver, the brain, which could clearly then have long-term negative consequences. So for all of these different pathways, there's different potential biomarkers that might be objective ways that we can measure impairment of these different symptoms that then might contribute to long COVID. So not only could we measure these different biomarkers, but we could also perhaps intervene on them to then reduce or prevent long COVID. So now on to the data source, which is the National COVID Cohort Collaborative, or N3C. So while countries with nationalized healthcare systems like Denmark often have a centralized repository that includes nearly all of the health data of citizens in the country. In the US, as you likely know, we have a pretty fractured system where then different healthcare providers don't really share data with each other, and that it's challenging for those providers to then share data with researchers. During the COVID pandemic, the NIH kind of recognized that this was really hard for then researchers to conduct national analyses on COVID-19 data. So they negotiated between all of these different healthcare providers to essentially say, okay, will you share your data with us as long as the NIH or NCATS manages data access, manages data security, so that researchers will have to analyze data within our secure platform, and they'll have to pursue COVID-related research questions. And I think by nearly all metrics, this has been a really successful endeavor. It now includes more than 22 million patients from 83 different healthcare providers across the United States. And that they've just recently expanded for an additional 5 years of funding, and that they'll also be expanding beyond COVID to look at other health outcomes. So I'll circle back to this later, but I think kind of any students who are looking for either a data source for your capstone or your dissertation or anything like that, I think this is a really rich data source that I think now there's a pretty clear institutional support that this is going to not only continue, but expand. So strengths and limitations of N3C as a data source. You might note that almost all of these that I might put in the strengths or limitations column are actually kind of both, depending on how you consider them. So a strength of N3C is a really large sample size. So 22 million patients, I believe something like 30 billion rows of data is really, there's a ton of research questions you can pursue and be really well powered to do so. You have complete follow-up in that anytime an individual interacts with a participating healthcare system, their linked records will then be included. And there's really high quality data related to medications, comorbidities, and COVID-19 related factors. In terms of limitations, there's really heterogeneous monitoring. Unlike a cohort study or a randomized trial where you could pre-specify, we want to measure these factors every month or every year in all participants, we don't have that in N3C. You only have data whenever somebody interacts with that healthcare system and gets that measurement ascertained. Then there's also high dimensional data, which means that each participant is going to have many covariates. And so I'll describe a little bit more in a bit why that can be a drawback. But of course, it's also a benefit to have so much information. We also have a lack of biomarker data. While it's pretty rare that folks, whether you're presenting at your regular doctor's office or at a hospital, you're typically not going to have a ton of biomarker measurement that we might really care about in a research context, but might not be quite as relevant in that clinical setting. And then finally, there's limitations to generalizability. Given that there's so many researchers working with N3C, it's nice that these limits to generalizability are really well described. So generally speaking, the population skews towards college-educated, disproportionately white, disproportionately older and high comorbidity population that's interacting with the healthcare system more. But with that being said, it's such a large population that it does give flexibility in terms of how we account for this, this balance or imbalance in terms of representation. So now onto the analysis methods that we're going to cover. This is really just going to scratch the surface of this analysis approach, which is a targeted machine learning, also known as kind of a causal inference roadmap approach. But I just want to give enough of a context so you can see why these methods fit so well with this data source and research question. So targeted machine learning methods are essentially applied machine learning for causal inference, and they leverage advancements in causal inference, biostatistics, and data science. Two of really the main components of a targeted machine learning framework, and the two components that I'll use here are superlearner and targeted maximum likelihood estimation. Superlearner is an ensemble machine learning algorithm, which means that you can introduce a library of candidate algorithms or a list of algorithms that you think might work for the data. And then superlearner will determine the optimal weighted combination of those candidate algorithms. A really nice thing is that you can then choose a really diverse library. So it's a best practice to include both parametric algorithms, things like generalized linear models, and then non-parametric algorithms. So things like kind of what you might think of as more stereotypical machine learning algorithms of gradient boosting of random forest. And then I think a nice thing is it's great to have theory and to talk to biostatisticians about the rationale for including different algorithms, but then allowing superlearner to make some of those tough decisions about algorithm selection. So, and then a nice thing that I'll circle back to later is that superlearner can maximize any given parameter. It's often going to be something like minimizing the mean squared error, but I'll describe in the first application why we used a little bit of a unique parameter, where then superlearner chooses the best combination to then maximize whatever that parameter is. And here I want to note that that's really where machine learning methods typically stop, and that they might have I think they have the apt stereotype that they often have low interpretability and that you can't draw causal inference from machine learning models. So here is where we really bring in the second big component of targeted machine learning, where we bring in targeted maximum likelihood estimation. This is primarily a bias reduction step. So we're saying we don't want to just predict long COVID. We want to determine how one factor causes a change in long COVID. How does COVID-19 vaccination impact long COVID? So we're optimizing this bias variance trade-off, perhaps saying, okay, we'll give up a little bit of precision to really remove bias and hone in on this causal relationship of interest. Another huge benefit is that this yields a parameter interpretable to non-statisticians. Rather than most machine learning algorithms will yield something like a non-parametric measure of association that's really not that interpretable. This will yield something like an average treatment effect, or even something more creative like an optimal treatment regime that can really be relevant to clinicians or policymakers. And then finally, it's a double robust estimator. So then why, kind of highlighting how these methods apply so well to this data source. So high dimensional data, a lot of covariates. That is going to make it really likely within a traditional parametric model, something like a generalized linear model, we have to specify or parameterize the relationships between all of our covariates. That means that we're going to be making a ton of assumptions about what those relationships look like. If we have a ton of covariates, that means a ton of assumptions, and it's really likely that some of those assumptions are going to be wrong. Another term for that would be model misspecification. So anytime we have model misspecification, that's going to induce some bias. Superlearner is a great way of getting at that then we can include kind of a really diverse array of candidate algorithms, and we can really select the best combination of those algorithms to then have minimal parametric assumptions. So then next, because it's really big data, large sample size, we have really high precision. In other words, really tight confidence intervals. While we would often think of that as a good thing, a really well-powered study, the issue is that if we have any bias at all in a really large sample size, that means we're going to be, it'll have really high precision, but low accuracy. In other words, we're going to be so confident in what could be the wrong result that could be really problematic. So here, both superlearner and targeted maximum likelihood estimation are going to be really useful. Superlearner in really having those minimal parametric assumptions that we described, really letting the data speak for themselves. But then targeted maximum likelihood estimation in then reducing bias. So then we can make sure that, yes, we have high precision, but that we have high precision that then includes that correct estimate. And then finally, there's the apt view that traditional machine learning has low interpretability and a lack of ability to make causal inference. And then that's where targeted maximum likelihood estimation is so useful. We can incorporate a lot of these causal inference considerations, we can reduce bias, and we can yield a interpretable causal estimate. So now jumping into our first application. So our first application is the Long COVID Computational Challenge, which they called L3C, which used data from N3C, the National COVID Cohort Collaborative. The goal here was to predict long COVID diagnosis based on individual patient history using N3C data. They provided us with a sample of 57,000 patients that were matched at a 1-to-4 ratio of long COVID patients to not long COVID patients. And then they evaluated our model that we created using an additional 10,000 patients that they held out from us and they just used for testing. The sample was censored 28 days after acute SARS-CoV-2 infection. And the reason for that is because while the definition of long COVID varies, many of those definitions focus on somebody being at risk based on their symptoms that are at least 28 days after acute COVID infection. And then our models were primarily evaluated using a metric called the area under the receiver operator curve, or AUC, which is a common metric of discriminative ability, or essentially here predictive performance. To then jump to the competition results, although I'll explain some of the details a bit more. We received an excellent predictive accuracy with an AUC of 0.95. And for context, anything really over 0.9 is considered kind of the gold standard of being a really highly predictive model. So we were really happy to kind of reach that threshold. We received third place in the competition, which also included a $100,000 cash prize, which was a really fun way to start off the first semester of my postdoc position. And then we then processed this competition entry into a manuscript that's now available via medRxiv, and I've posted the link here, and I'll be sure to share these slides after the presentation. And the manuscript is currently under peer review at JMIR Public Health and Surveillance. In terms of our methods, that we extracted 304 features from the electronic health records that we thought would be relevant to long COVID. We then indexed those features across 4 time windows because we really wanted to be able to parse in terms of interpretation. Are these characteristics related to acute COVID infection and severity, or are they just baseline factors? Are they characteristics after acute COVID-19 infection? So the windows we used were baseline, which was more than 37 days before COVID-19, pre-COVID, which was between 37 and 7 days before COVID, acute COVID, which was 7 days before to 2 weeks after. We started 7 days before because we got kind of the insights from clinical collaborators that it was likely that somebody has COVID well before they actually present at the healthcare center to get tested, which would be the date that they actually had. And then the final window we had was post-COVID, which was between 2 and 4 weeks following acute infection. We assessed variable importance via Shapley values based on 3 groupings. First, we looked at the individual features, so all 1,339 features. Then we evaluated based on the 4 temporal windows. And then finally, we evaluated based on 14 domains of interest, where we grouped the covariates into kind of related groups, again, to then just kind of get a better idea in terms of interpretability. So starting off with a prediction by the temporal window. Here, and I think that this is among the most important kind of clinical implications of our findings, we found that baseline factors were the most predictive of long COVID. That was pretty surprising to me, where I thought it would definitely be post-COVID factors. That, in my mind, the symptom that somebody has between 2 and 4 weeks after COVID, it almost feels like then that's almost long COVID already. It almost feels like splitting hairs then to say the post-COVID period versus long COVID. But that we actually found that by and large, those baseline factors were the most important. So this supports that clinicians might be able to accurately forecast a patient's long COVID risk before they even get COVID, just based on these baseline sociodemographic medical history factors. So then this would really allow early recommendation for preventive treatment and continued monitoring. That, for example, the moment somebody presents with a potential case of COVID-19, if they have kind of a high score in terms of long COVID risk, they could immediately be referred to either additional screening or preventive care. So next, here's the ranking in terms of Shapley values for the 14, we describe them as clinical domains. So we found here that healthcare utilization was by far the most predictive category. That's really consistent with the literature. In other words, healthcare utilization is how often somebody goes to the doctor or how often they interact with any of these healthcare providers. So I'll circle back to this at the end, but because really we want to unpack moving forward a little bit more, because the issue in terms of social determinants of health and inequality as they pertain to healthcare utilization and, more importantly, access to healthcare is a really important question. So although this might not have as clear kind of biologic mechanism as some of the other domains we described, I do want to just kind of underscore that as an important area. So then next we had sociodemographics, which again would be kind of primarily a baseline factor as a important domain. And then as the third most predictive domain or group of characteristics, we had respiratory factors. I'd probably highlight that as one of the more potential biological mechanisms. And it's also consistent with the literature. So both respiratory symptoms are the most common reason for long COVID diagnosis. Things like dyspnea or shortness of breath and cough are really common reasons to get diagnosed with long COVID. But there are also factors during acute COVID infection that are associated with a subsequent long COVID diagnosis. So limitations. This analysis sought to maximize prediction rather than make any type of causal inference. So as kind of underscoring some of those limitations of that approach, so we incorporated post-COVID factors, which could be mediators of the relationship from acute COVID to long COVID. But on the other hand, for example, respiratory factors could reflect susceptibility to severe acute COVID. So something like asthma could make somebody more vulnerable to severe acute COVID, and therefore more vulnerable to long COVID. And then that factors related to medical visitation, which are highly associated with long COVID, might just be associated with increased likelihood of any diagnoses. If you go to the doctor more often, you might be more likely to get diagnosed with anything. And this might not be a unique relationship with long COVID itself, and particularly might not be associated with higher long COVID incidence. So now we moved on to a more causal inference focused analysis. And then to highlight the first analysis, just used the superlearner half of the analysis, while this analysis will use both superlearner and targeted maximum likelihood estimation. So this analysis evaluated the relationship between the use of selective serotonin reuptake inhibitors, or SSRIs, during acute COVID-19 and subsequent risk of long COVID among patients with depression. And this manuscript is available via medRxiv. So the motivation for this article was that in October 2023, there was really an excellent article published in Cell that kind of has gotten a lot of traction in literature and media that argued that low serotonin was a key driver of nearly all long COVID symptoms. They found this in both human and animal models. And I'll get a little bit more into the biology of this in a couple slides. So a nice thing for us, because there have been multiple biomarkers that have been implicated as relevant for long COVID, but biomarker data, as I mentioned, in EHR or electronic health record databases like N3C is pretty limited. But on the other hand, there's great medication data in N3C. And serotonin is a biomarker that has a great pharmaceutical analog, which are selective serotonin reuptake inhibitors. They increase bioavailable serotonin and may be an effective intervention to prevent or treat long COVID based on this hypothesis. So then I created this kind of biological flowchart to then explain some of the hypothesis of this previous article by Wang et al. And our more recent manuscript. So of course, COVID-19 starts with a SARS-CoV-2 viral infection. And this infection then leads to the release of viral-induced type 1 interferon. And then there's several consequences of this release of viral-induced type 1 interferon. But Wang et al. Found that in folks who had long COVID symptoms, there was actually a reservoir long after the healthy patients had then purged all of the SARS-CoV-2 virus. The long COVID patients actually still had a reservoir of SARS-CoV-2 in their gut. And these viral remnants were then leading to a continued, over a long time, release of viral-induced type 1 interferon. And this interferon leads to hypercoagulation and platelet dysfunction, which then already kind of explains one of the long COVID domains of symptoms. But it also leads to low serotonin. So this interferon prevents the uptake of tryptophan, which is a precursor to serotonin. So it, in essence, prevents the production of serotonin. And then low serotonin impairs neurologic and vagal functioning, which leads to issues with sensory issues in terms of smell, taste, issues with sleeping, issues with anxiety, depression. So really in one fell swoop, we've explained a lot of these long COVID symptoms with one biomarker. So for our study design, in a cohort of patients with depression, we evaluated the relationship between SSRI use during acute COVID-19 and subsequent 12 months cumulative incidence of long COVID. We restricted to only include patients with depression, which is the most common reason for SSRI prescription, to limit confounding by indication. In other words, if we were comparing depressed patients on SSRIs to non-depressed patients not on SSRIs, those populations are likely to just be fundamentally different. And so we rigorously adjusted for healthcare utilization, comorbidities, and we intervened on outcome monitoring, which was whether a person went to the doctor between 1 and 12 months after their acute COVID infection. So to then just, to jump into our table 1, our sample included 507,000 patients where about a quarter of them were using an SSRI during acute COVID-19. And we found that SSRI users generally had higher healthcare utilization and more markers of poor health. For our results now, we found that SSRI users had a lower risk of long COVID compared to non-users. And that'll be that first row at the top. We also evaluated the relationship between SSRI use and long COVID among the subgroups of different SSRIs, but we didn't find evidence of effect measure heterogeneity depending on SSRI type, which was pretty consistent with the insights of our clinical or psychopharmacologic colleagues who kind of indicated that all of these SSRIs would have a fairly similar mechanism. So what I do want to highlight is, although we found a protective relationship in the adjusted relationship between SSRIs and long COVID, the unadjusted association indicated a harmful relationship. So in other words, the adjusted relationship showed a risk ratio of 0.9, while the unadjusted relationship indicated a risk ratio of 1.2. And that's, again, on that first row at the top. So given this large qualitative shift in our estimate following multivariate adjustment, we wanted to unpack a little bit more of what was driving this confounding. So here we have our full model, our fully adjusted model, and then we compared that to the estimate if we excluded first one by one each adjustment covariate, and then we excluded entire groups of covariates to get a better idea of how a whole kind of category of covariates might be influencing these estimates. And in general, we found that measures of healthcare utilization were the strongest confounders, which again is very similar to our main findings of our first prediction analysis. And here at the bottom, we had those are the groups of covariates where we group together healthcare utilization factors and then general health and comorbidity factors. So some strengths and limitations of these findings in this study overall. So the strengths really come from the targeted machine learning methods and the N3C data source. So targeted machine learning allows flexible semi-parametric estimation, which then minimizes assumptions and avoids model misspecification. And we also had really rigorous adjustment for heterogeneous monitoring that targeted machine learning methods really enable. Also, N3C as a data source was really a huge strength. So we had a really large sample size with relatively complete follow-up. And we had high quality data related to medications, comorbidities, and COVID-19. So limitations. One would be our definition of long COVID, which was this binary diagnostic status. And as I mentioned, this has a pretty low sensitivity. It also doesn't really allow us to parse out what might be different phenotypic subgroups of long COVID. For example, neurologic long COVID versus gastrointestinal long COVID. And then we also assessed SSRI use at the time of COVID-19. We chose this because in using a kind of emulated target trial framework, we might enroll these patients at the time of drug prescription, but this would require an active comparator. And in other words, would be a drug that's prescribed for depression that has no impact on serotonin. And from our literature review and talking with clinicians, those drugs really don't exist. Anything prescribed for depression is, at the very least, is going to have some indirect impacts on serotonin. So there really wouldn't be a great active comparator there. So here we decided to use a prevalent user design, which was looking at who was already using SSRIs at the time of acute infection. So this could include some residual bias due to history of SSRI use. And we also had insufficient data to really fully evaluate SSRI dosage or duration, but that could be a good target for a future study. So in terms of main takeaways from this, SSRI use during acute COVID-19 is associated with a reduced risk of long COVID among patients with depression. This supports SSRIs as a potential intervention to prevent or treat long COVID. And this also provides support for the biological mechanism that we shared earlier, that serotonin may be a mechanistic biomarker of long COVID. And furthermore, this provides indirect support for the other components of that mechanistic hypothesis, which are that remnants of SARS-CoV-2 virus drive long COVID through the sustained release of viral-induced interferon-1 and decreased tryptophan uptake. So all of these processes could be potential mechanistic biomarkers, which means that we could either intervene on those to prevent or treat long COVID, but we could also maybe measure those to detect long COVID. So then circling back to our previous flow chart, but now I've kind of put in bold the pathways that have been highlighted by these results. So here we see the really emphasizing persistent SARS-CoV-2 as being supported by these findings. But that has impacts on inflammation, that this persistent SARS-CoV-2 leads directly to long COVID symptoms, that this exacerbates clotting and platelet issues, and then this also can lead to stress neurobiology disruption. So now future steps. There's a lot we've been building a lot of momentum across these projects. One, as I mentioned, these really consistent relationships between healthcare utilization and long COVID. So we want to evaluate the relationship, or rather evaluate racial bias in long COVID diagnosis. So in other words, we have all of this symptom data in patients. So looking at comparing folks who present to a clinician with an identical symptom profile, depending on their racial group, is there a differential probability that they will actually get diagnosed with long COVID? And again, this will be a conservative comparison because we don't have folks' true symptomatic status, and there might still be bias, or there will still be bias in terms of this documented symptom status. But I think finding this diagnostic bias could be a really helpful tool in identifying some drivers here of this inequality in these outcomes. We're also looking at COVID-19 vaccination timing relative to acute COVID and risk of long COVID. So in other words, if I got a COVID-19 booster today, and then I got COVID in April versus got COVID in March 2025, would there be a different probability of me then subsequently getting long COVID? And that would really be a helpful tool to learn about waning protection from vaccination with respect to long COVID. We're also testing a few medications that might be able to prevent long COVID and have some kind of limited evidence, whether theoretical or applied, to prevent this condition. And those are metformin and immune modulating drugs. Metformin, which is a common drug among diabetes patients, and immune modulating drugs, which are commonly used for rheumatoid arthritis. And then finally, we hope to follow up by conducting all of these analyses, sort of replicating them using clusters of long COVID symptoms rather than just this binary long COVID diagnostic status. So I just want to acknowledge an incredible team of collaborators. So I think really, I have to give a huge thank you to Wendy G and Sarang Deshpande, who are Wendy is a biostats PhD candidate, and Sarang is a graduating undergrad student. And they both have just done an absolutely incredible job across all of these projects. But I just want to thank the whole team at CTML as well. Jack Holford and Alan Hubbard have done just an incredible job as mentors. And more broadly, as a huge thank you to everybody at N3C, but then also as a recommendation to any students who are interested in working with N3C data. I've been blown away by folks' supportiveness and openness to collaborating, that literally every person I've sent a cold email to say, hey, I like your paper, can we talk? Not only have they said, yes, let's talk, they have all said, let me share code from the analysis. What can I do? Can I help you process your cohort? And it's really just been I just continue to be blown away by how supportive everybody has been. So if you're interested at all in working with this data source, please let me know. There's a little bit of a kind of run up in terms of onboarding process, but I think it's really an excellent data source. And I also want to thank our funders and just the whole team at UC Berkeley. I also want to thank all of the N3C support and contributors. And then here are my references. So thank you so much, everybody. And then we have about 10 minutes for questions.
Great. Thanks so much, Zach. That was super interesting. Wow. It's great data and such interesting results. Thank you for sharing.
Thank you.
If people want to post questions or raise your Zoom hand and unmute, happy to have some discussion. I have one quick question while other people might be thinking of questions, and I'm sorry if I missed it in the beginning, but did you control for age and gender, or would you expect to see any age or gender differences?
So great question. Yes, we did control for age and gender. And I think that, yes, we would definitely expect to see differences where long COVID is disproportionately older folks and disproportionately women. And that, again, that's mostly referring to diagnosis rather than kind of true underlying incidence. But so yes, we did control for those factors, and I have here, I'd be happy to share kind of our full, we probably controlled for, I think we probably had 30-ish adjustment covariates. So I cut them here for length, but would be happy to share them if they're interesting to folks. Hi, Jen.
Thanks.
Of course, thank you, Lauren.
Great talk, Zach. That was so interesting. I was like eating my lunch, riveted. So that was great.
Awesome.
I had a question. I really appreciated in your predictive model, your sort of first paper that you shared, that you made an effort to do some kind of interpretation of the strongest predictors. I think, doing something around variable importance really helps the model not seem so much like a black box. And I just wanted to give you an opportunity to maybe say a little bit more about how you thought about that. Were there alternatives you considered? And like, how did you decide on the way you went in terms of picking the sort of way to show the variable importance?
No, thank you for that, Jen. Yeah, that was an area where we definitely spent or I guess I spent a disproportionate amount of my time really obsessing over slightly different variable groupings. And so, and we really wanted to have kind of this, well, the competition itself actually didn't request any type of additional variable importance metrics. We really thought that it wouldn't be that useful to just present 1,400 measures of individual variable importance. So I think in terms of temporality, so we grouped based on those 4 factors, and I'll kind of jump back to where I was also. So here we grouped based on 4 factors, which were these 4 time windows, where I think that one part is we kind of wanted to follow the example of some of the previous literature as well, that I think largely had sought to separate the baseline, immediately pre-COVID, acute COVID, and post-COVID windows, which again, I was really sure that this post-COVID window would be the most predictive. So I was really surprised to see baseline carry a lot of that weight. And then here, where I think one disclaimer is that these groupings many are incredibly, they were non-overlapping, but I think conceptually have a lot of overlap. That distinguishing, for example, respiratory from cardiovascular factors, those systems are so intertwined. But I think to then also contextualize in the context of our later findings, seeing this COVID-19 positivity as our fourth most important category, that supports this kind of remnants of SARS-CoV-2 virus pathway. And that we kind of glanced over that in our initial presentation of these findings, but now finding that consistency with our later paper is making us kind of pay a bit more heed to that. And that we got to revise and resubmit from JMIR, so we're actually adding a bit more variable importance. I think that it's another great thing of working with the Center for Targeted Machine Learning is we've been able to kind of develop some slightly like bespoke methods in terms of drawing a bit more variable importance. But sorry, did that answer your question, Jen? Awesome, thank you so much.
Thanks. I see there's a question from Tulika and then Brian.
Hi there, this is Talika. Just a quick question. I was wondering about what you meant by the healthcare utilization. So you said that that was very well known to be like a sort, is that because it's like a confounder with so many other things, or is there something specifically about healthcare utilization that is causing harm?
Excellent question that I think kind of, so I think I wouldn't say causing harm, but I think like I would put it into two main kind of buckets of hypotheses. So there's one that's just that long COVID itself is a little bit of an amorphous condition that's kind of challenging to diagnose, because that, for example, things like headaches, insomnia, anxiety, if you present to that doctor, I think there was a really interesting study that said for somebody to get a long COVID diagnosis, it typically takes like at least 6 months and 5 doctor's visits or something like that, because it just takes so long to rule out other things and it's not really commonly diagnosed. So I think that that's one hypothesis is just if you go to the doctor more often, you're more likely to get diagnosed with anything, but then you're also more likely to then get this type of more nuanced diagnosis. On the other hand, it could be that people who are going to the doctor more often have this really high, and this is really focusing on like pre-COVID healthcare utilization, because I think post-COVID healthcare utilization, maybe they're going to the doctor a lot because they're really sick with long COVID, and it's already the case. But I think it's also totally plausible to say that folks who go to the doctor a lot have a lot of comorbidities. They have a lot of other diseases, maybe they're more medically vulnerable, and that medical vulnerability is really like demonstrates that is a biologic pathway to long COVID, that like this is a real risk factor. It's not just confounding. So I think then really parsing out those different factors is something that I'm really interested in. And I think then furthermore, I think having better ways that we can describe and diagnose long COVID, because seeing that drop off from like a prevalence of, let's say 20%, but then a 2% diagnostic rate is a huge drop off, which then when you have that huge drop off, it's not shocking that you're going to see a ton of inequality and bias in terms of who are that 2% that really get captured. But great question, Tulika.
Thank you.
Of course, thank you.
Thanks. Brian, I have time for one more question. Yeah, Brian, go ahead.
Hi, thank you for a great presentation. I was just curious, based on your findings and maybe your own curiosities, what types of qualitative research questions might be worth exploring to complement this research?
Oh, that's an awesome question, Brian. I really like that. So I think, so I'm sure that there's a lot of different directions to take that, but I think the one that strikes me most is qualitative work summarizing patient experience of long COVID patients. That I think one group that I've kind of collaborated with a fair amount and I think does really great work is called the Recover Initiative, which is like an acronym, but like for around COVID recovery. And they have a pretty robust, totally not to say that it couldn't be improved, but then patient advocacy and patient representative network But I think because I think it's in my work, it's like easy to kind of read, like, I don't know, something like headaches and like, oh, this is a pretty mild condition. But then talking with a lot of the patients and hearing that experience of how long it takes so many patients to get a diagnosis, and that just really imagining how the vast majority, likely, whether they don't have the resources to keep going to the doctor to get the diagnosis, or don't have the energy, or don't have the time, but that I think that type of qualitative work around long COVID patient experiences, I think, would have a ton of value.
Thank you.
Awesome. Thank you, Brian.
Great, thank you. I know we're at time, so thank you everybody for joining today, and thanks so much, Zach, for sharing your work. And
Thank you so much.
a good
Oh, and
day.
definitely feel free to reach out to me via email if you have any questions.
Great, great. Thanks so much. Take care, everyone.
Thank you.
Bye.